TOPICAL trial is to try to capture patients who are not suitable for chemotherapy treatment. I think, as you heard in a plenary session discussion by Dr. Adamant, very few patients, in fact, in US alone, when they look at their data, the Siow data involving over 20,000 patients, only 25% of patients get any form of first-line chemotherapy treatment. I think in UK, when we look at our Lucada data back in 2007, involving over 24,000 patients, only 25% of the patients get any form of chemotherapy treatment. So first-line treatments are not given in many patients out there. And all these patients, I suspect, are over 70s. And in the TOPICAL trial, our median age was 77.4 years old for the patient receiving Erlotinib, and 77.2 receiving placebo. Over 80% of these patients are over 70 years old. I think the general feeling is that the majority of patients with lung cancer are over 70 years old. So the idea about the TOPICAL trial, apart from they receiving palliative radiation treatment or any symptomatic care, whether Erlotinib, or people know as Tarceva, actually add any benefit to this very poor performance status patient. We already know, since the study was originally designed back in 2002, there have been subsequent studies showing Erlotinib is beneficial for patients with PS2 and 3 patients, or also after first-line chemotherapy when used as a maintenance treatment. The message is that even though we did not see overall survival benefit, we did see improved PFS benefit. If I remember correctly, the PFS benefit was 0.76, which is equivalent to 24% reduction. I need to check on that figure. When we look at the planned subgroups, including gender, histology, EGFR mutation status, smoking history, and whether patient received palliative radiotherapy or no palliative radiotherapy, histology, I mentioned histology, and the thing that came out for overall survival was the gender effect, which was rather surprising to us because we don't see all in the other subgroups, but only gender. But when we look more deeply into it, we found there was a gender interaction between male and female, and what was driving the survival benefit. When we look at the subgroups, we didn't gender. So we found if you got, you're female, regardless of any histology, you're female, whether you're current smoker or ex-smoker, or you are female with performance status 2 and 3, you achieve a significant benefit in terms of progression-free survival. We see a very similar trend in overall survival as well. But we don't see it in the men, which was a very interesting finding. It's interesting to hypothesize why that happened. Maybe in the Western world, the life expectancy of the men averaged about 77 in UK, I think 75 in US, whereas women average 80. Whether they actually get any benefit from this Tarceva treatment, we don't know. We look at the smoking history, so obviously more female are non-smoker, but I don't think the benefit is so in female. So we're talking about benefit of overall survival for female, benefit of PFS for female, and we also look at the 1-year survival time point. And interesting, in the female, at 1-year time point, 3 times as many female patients remains alive and disease-free compared to the female patient taking the placebo. I think this is quite an important observation. And I don't know how frequently people use Tarceva for poor PS patients. I understand in America, they use it very frequently. I suppose, they need to think carefully whether it's worth using for the male population. But nevertheless, we saw this benefit in the female population. In our study, we actually show only 3.5% of this population has EGFR mutation. Majority of the Western smoking population have what we call the wild type, EGFR wild type mutation negative patients. So these are the real world, they are very common out there. So we also need to focus on this population rather than just thinking about this mutation. Obviously, they are important, they are the super responder, but nevertheless, the majority of the patients are mutation-negative population.